Hello, everyone, and welcome to today's webinar, The Surge is Here, How to Manage Credentialing and Enrollment Spikes. We're thrilled you've joined us and look forward to sharing practical strategies to help you navigate surges, whether they're planned or completely unexpected. Before we dive in, just a few housekeeping notes. We want this session to be engaging and worth your time, so please ask your questions. You'll also have a chance to participate in a fun trivia game, so don't be shy. Today's webinar is being broadcast live on GoToWebinar. All attendees are on mute to reduce background noise, but you can interact with us using the questions panel on your screen. Drop your questions anytime and your trivia answers too, and we'll keep an eye on them throughout the session. You'll also find several helpful resources in the handouts panel, including your NAMS Continuing Education Certificate. Simpler is excited to announce that this program has been approved for NAMS Continuing Education credit by the National Association of Medical Staff Services. Be sure to download the certificate. We will also email it to you within a few business days. And then for those of you who may not know us, we are a healthcare operations technology company with more than 30 years of experience supporting hospitals, health systems, health plans, and non-acute organizations. Our mission is to simplify healthcare operations so caregivers can focus more on patient care. And today, simpler solutions are used by 9 out of 10 US hospitals and over 400 health plans. What sets us apart is that we're the only healthcare technology vendor that is connecting the entire provider lifecycle, linking credentialing, privileging, enrollment, scheduling, quality, and clinical communications in a single platform. So that means fewer silos and better data flow across departments. And ultimately, the right providers reach the right patients at the right time with the right care. So with that, I'm going to turn that over to our host, Amy Magnus and Teresa Grant, to get us started.
Okay, good afternoon, everyone. I'm Amy Magnus. I'm the Director of Credentialing Operations for Simpler CDO. I have been in the industry for a little over 10 years now, and before joining Simpler CDO, I had held some positions in medical staff offices of a critical access hospital as well as an acute care hospital. In these roles, I did gain much experience, obviously, in credentialing, privileging, quality assurance that included the lovely FTPE and OPPE and policy management. And thankfully, I did also have the opportunity to work in risk management and peer review, which gave me further insight into the whole practitioner lifecycle.
All right, and I am Teresa Grant. I'm Director of Payer Enrollment Services at Simpler. My education was actually originally geared towards the clinical aspect of healthcare, and I transitioned into the administrative side of things a little earlier in my career, specific to the management of payer enrollment. I've been experienced with the full spectrum of payers in almost all 50 states for over 15 years. I have experience with commercial, government, delegated, non-delegated, you name it, I've probably done the enrollment. And in that time, I've worked with a variety of organizations across the US to streamline their enrollment turnaround times, reduce billing holds and denials, make sure provider onboarding experience is as painless as possible, customizing that to org structures and needs. Really also enjoy process improvement and client relationships.
Perfect. Well, we are going to start this off with a poll. So we do want to learn a little bit about you and your organization. So we will open up for about 30 seconds to a minute. We just want to see exactly where you're coming from, if you're hospital, non-acute, or more in the payer realm. We will, again, leave that open for a little bit. Watching it. Of course, majority is going to be in our hospital and health system area. Looks like we have about 64% of you are in the hospital. So, but I'd love to see that we have some others from our non-acute and our payers as well. Okay. So today we are opening the conversation with addressing some of the biggest credentialing and payer enrollment challenges You know, we all are at different, I think, positions and in different types of organizations. And so, you know, some of us work for the hospital, some are payers, but, you know, today we do share one common goal, and that's to ensure that, you know, ensure our patient and member safety and obviously healthcare quality. So we definitely want you to leave with a clear action items to improve your organization. So we will discuss how to manage credentialing surges more effectively, how to recognize common pitfalls, some solid workflows to help reduce those gaps, as well as, of course, any potential AI and automation that can better support your work.
All right, time for another poll. So on this one, we really want to hear from everybody. As Amy said, we want people to get things out of this webinar. So the question is, what's your biggest challenge during credentialing and enrollment surges? Answers are delays due to disconnected workflows, not enough staff to manage volume, duplicate work across teams, lack of real-time visibility into status, misalignment between credentialing and enrollment teams. We felt these were the major themes, but if anybody has anything specific that they'd like to call out, please use the chat function and drop a note for us as well.
There it is. I think that is kind of a common thing of not having enough staff to manage the volume. And, you know, thankfully there are things that you can do to help kind of take some of the burden off and be able to streamline things a little bit better. So hopefully. And okay, so we will start off with our first discussion topic, which are some of the common pitfalls and, you know, top mistakes that we see from both the credentialing and enrollment aspects. Okay, so I think one of the biggest things that we see, I think even from a CBO side of it is, you know, we have dual clients as well, but also as well as, you know, my experience being in the hospital setting is, you know, having siloed departments. You know, at this point, I think a lot of people are really understanding how, you know, enrollment and credentialing departments should really work together. And when they don't and they're operating independently, it can often result in a lot of miscommunication, you know, delays in the practitioner, not only, you know, obviously being enrolled and getting paid, but being able to work. And then frustration from both the administrators who are obviously pushing us to get these done, as well as the practitioner. So we always have to keep in mind that this is the first impression of your organization. And at the end of the day, we're asking a lot of the same information and documents from them. So it adds on that additional administrative burden. And, you know, one of the things that I always say, you know, why would a practitioner want to stay with the organization if they feel it's so unorganized and inefficient? You know, this also comes back around then for, you know, reappointment time or even like a CAQH maintenance situation that, you know, if we're not helpful with them like at the beginning, then, you know, it's going to make it difficult for them knowing that, oh, it's coming up again in another few years. Some of the, I guess, examples that I've experienced in the past and of really siloed areas are, you know, hearing about a practitioner who's starting at a clinic who went through HR. Again, this is an employee practitioner. So they went through HR, they went through all the appropriate channels, but they never came through the medical staff office to be privileged. You know, finding out on social media that they're starting the next week, which obviously that had to come to a halt. And that is, you know, very frustrating, I think, for everyone. Oftentimes, you know, I would hear about, you know, new services that were not privileged or new practitioners that were coming while I was sitting in the middle of a meeting. And so now I have to start, you know, asking questions. And again, it all comes from everyone not communicating and having these siloed areas. I think another piece of it too is also thinking about siloing your facilities out. So these health systems that have multiple locations, you know, that is where it can be quite difficult. You know, there obviously are ways to streamline it a little bit better, but you know, when you're sending practitioners through initial and even reappointment, you know, you want to avoid making them go through that process multiple different times, having the duplicative approval processes, not aligning your reappointment date. And it becomes very disjointed and a very inefficient process. And especially, it does not work when you have a large number of practitioners. You want to get through them as quickly as possible. And when you're doing it multiple times, obviously, not only do you have a large volume, now you also have a large number of processes you have to get them through.
And just adding to that, really speaking to outdated tech or no tech, some people are still using Excel spreadsheets to track their provider statuses, and as well as any reporting tools, right? So educating the organization, people are sending out spreadsheets that they update by hand. And especially going back to the poll question where most of you answered that there weren't enough staff to manage volumes. It's really, really important to make sure all departments are on the same page and optimize processes where possible. Instead of having 3 departments ask for a license because we need it for credentialing, licensing, credentialing, privileging, and enrollment, it's much more efficient to bundle where you can and use each other as resources. And again, that goes back to tech and reporting tools, because if you all have a source of truth or something that you can compile your data to use and stay on track with, that takes you a long way. But we'll get into that further in the next few slides. Speaking specific to payer enrollment, something that I know is always an issue, especially during surges, is unrealistic expectations. In enrollment, I think we all know this, everything is always a priority. And then what happens is nothing is ever a priority because everything is priority. It's really hard to get a grip on that. So it's important to make sure everybody's on the same page as to how long it actually takes to enroll a provider. As an example, if you receive a new provider to enroll and credential 10 days prior to their start date at a facility, you can guarantee that that provider will not be enrolled and ready to bill for services when they show up at the hospital on their start date. So it's important to minimize issues like that where possible. Another item I see as an issue is lack of strategy and disorganization. And again, this goes back to making everything a priority. Continuously reprioritizing new providers that get dropped onto your desk that may have a more urgent deadline than the ones that were already on your desk. You need to figure out a process, and again, we'll get into this further on the next few slides, that works for you to strategize and optimize submission process.
Yep. And then, although this is listed more under the credentialing aspect, is kind of across the board, I think, just in general within organizations. And one of those pitfalls is lack of change management. So, these surges can really expose those operational cracks. And just like, Teresa has mentioned, of using kind of these old, outdated tools, possibly using any old and inefficient processes and having no real central source of truth, those clearly can create some issues. And but then people don't want to change. I know change is very hard, but we have to really be flexible and be willing to update what is necessary to make it easier on you. Another thing too is when it comes to change management is clearly you need to know your bylaws and you need to know your policies and procedures, but you also need to be aware of the approval process and how to change those if necessary. I think a lot of people get caught up in, making change to that, but there's an approval process in place to be able to make changes as needed. Additionally, is forgetting our why, and not losing sight of why we do what we do. We get so caught up in all of our processes and all the changes that are coming down, and with all, I'm going to say it because we're going to talk about AI and automation and all of those things, and all these, the higher volume surges coming in, and all of, we're always go, 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 go. But then we forget why we're doing what we do, which is all about our patient safety. We're not just paper pushers. We have a very important role. And, oftentimes we need to go back to our mission and, why are we here? And for both, I think, both payer enrollment and credentialing sides of the house, we need to, it's all about the patient and ensuring that we're protecting them. Okay, and I think this is our last poll. And so we want to know how you would describe collaboration between your credentialing and enrollment teams today. So obviously we mentioned how a lot of organizations have been siloed, but there are some who are definitely taking that step to work closely together. So just kind of want to see exactly where everyone is. Let's see. Wow, I am very impressed, everyone. So yeah, it does look like a lot of you are working very closely together, maybe somewhat aligned. But, I think in the past that has definitely been the opposite, and love seeing that. Okay, so our next topic are obviously what we're here for today. Some of the best practices to manage those surges more effectively.
So focusing on the middle bubble, where I think everyone has the same problem, the same best practices across the board, would be starting off with collaboration and visibility. So making sure, again, we kind of alluded to this earlier, but making sure all departments work together to create one onboarding packet and checklist up front for your providers so that they have the best possible experience and they're not being asked multiple times for the same items. And making sure that everybody on the team has access to an onboarding tracker or work system so that you're creating alignment amongst the teams and everybody's on the same page as to how we're tracking with the providers.
And I think I've seen both, where I've been involved where I have worked with our payer enrollment side very well. She had access into my system, obviously the access that she needed to get the documents that were required. So, it was all shared. But then I've also worked in organizations where it wasn't, and you could definitely feel, the separation. So, this also does, you have to kind of keep in mind, it's not just kind of the collaboration and visibility with payer enrollment and the medical staff office. You also have to keep in mind of your recruitment, maybe HR, if you have a separate onboarding team, and then obviously our two respective groups. Just like Teresa was saying, we don't want to ask for the similar documents because we are asking for practically the same thing. There's a few separate things obviously outside that each side needs, but yeah, why can't we ask for it all up front and really work together to make it a lot easier? It can definitely make a huge difference in how smoothly things go. So yeah, if we work together, it just definitely creates a process that's as seamless as possible. And then that's me. That's me. Going into kind of our practitioner communication and education and enhancing that. So I always highly recommend starting to develop that positive relationship early on. So when you know that a new practitioner is coming on board or applying, directly reach out to them and give them an overview of the process in general, explain why certain items are required. And so your role is to ensure your practitioners are well informed and understand what information is needed and why it's necessary. Providing that clear communication will ensure that you get what you need in a timely manner. We did. I know we have a few items available for download, and we did create kind of a guide that can help. That's kind of a starting point, obviously, edit as needed, that you can present to a practitioner so they understand all of the items that they need to provide and why. So, oftentimes, we we see this information day in and day out. We see it all the time. We know exactly what it is. We're super familiar with it, but these practitioners, they don't get a credentialing or payer enrollment 101, during their training. I will say I do hear some who are incorporating it into training nowadays, which is amazing, but they really don't. They have no idea when they're coming out that they have to go through these processes. So, we want to help them along as much as we possibly can. So involving them in the credentialing process, typically, you are going to get better responses in the long term. Even when it comes to, peer references tends to be a lot of the verifications that causes a lot of delays. But, when you're involving the practitioner in the process and the communication, then typically those come in a lot quicker. So just, involving them the whole time so they have a better understanding.
Definitely, I agree with that. And I'd like to add just a couple other things. Just from experience, speaking to Amy's point that providers really don't know what all goes into the process. Sometimes, I'm sure everybody on this call has experienced it, providers might think we're just asking for things to ask for them or to delay the process. This payer wants something signed in blue ink and the provider signed in black. And they think that we're making things up, that we're just trying to make this process harder for them. So as much education that we can provide up front really goes a long way. Another thing to add, if available, using a portal or a dashboard for them to be able to communicate with you and update missing items directly into. I think that helps optimize processes. And of course, assigning one team member to communicate with the provider throughout the process also goes a long way because they build a relationship with that person. And I will say, in creating that onboarding packet, you can bundle as much as you possibly can up front. In some situations, you still may need to reach out to the provider after the fact. For example, with privileging applications, there's a lot of collaboration with the provider that takes place. And there's outreach, and we have privileging specialists that partner with the providers to make sure everything moves through the process efficiently. But that, I will say, a lot of times cannot be bundled in that initial onboarding packet. Just something to note.
And then obviously if you have a very high volume, I will say, clearly getting all of the documents in quicker is going to get it through the process quicker. So the more reach out you have to do, the longer it's going to take to get that file done. So, when you have that high volume, you, again, want to make it as seamless as possible. So here's what we need, get it all back and get it through the process.
For sure. And then next item was setting realistic expectations. I think we've pretty much touched on this one, so I'm not going to spend a lot of time on it. But you need to set realistic expectations with the provider, with your practice management staff, and with your staff doing this work. Again, if you're notified of a provider 10 days prior to start date, they will not be enrolled with all payers when they start seeing patients. So you want to work together with all teams to make sure that you assign an appropriate start date for the provider.
Yep. And I would say same on, our side of the house too, that, you can provide timelines as possible. You kind of generally can get an idea of how long it's going to take you to process the file, and then, knowing your committee dates and, how long that's going to take. But, sometimes we're at the mercy of some of those verifications and getting them back. So again, that's why I say if possible. And so that's when I feel like a lot of times people think, oh, it doesn't take very long. I'm like, no, actually it does. So I think that's also ensuring there's realistic expectations for also the organization and the administrators and your leaders. So they're aware, because they're going to be the ones breathing down your neck trying to get it through. And so if you communicate to them, then, it will go a little bit smoother. But, always keep everyone informed about the process, especially maybe some high priorities, and then obviously communicating delays. And then I don't want to go too much into detail on automation, because we are going to address it a little bit further in the presentation, but Obviously, there are many options that can assist in a lot of our administrative burden that accompanies our day-to-day responsibilities. And, along with that comes the change management aspect and, incorporating, additional items into your processes. So leaders definitely need to have a roadmap for embracing that innovation without losing any of, of your great experienced staff or, potentially becoming non-compliant.
For sure. On the payer enrollment side of the bubbles, number one thing you need to do is strategize. So take a breath, take a step back, and look at everything that needs to be completed, all of the providers and their enrollments that need to be submitted. And then from there, try to prioritize those enrollments and batch them. Consider things like states or regions, payer backdating rules. So if a payer is backdating 365 days, you have more time to get a submission in than a payer that doesn't backdate at all. So you'd want to prioritize, obviously, the payer that does not backdate. Payer processing times. Usually those are the same ones that don't backdate that have extremely long processing times. So you want to make sure that you take that into consideration and try to get those out first. Another consideration would be prerequisite payers. So, for example, you want to get your Medicare and your Medicaid out the door as soon as possible, probably also your Blue Cross Blue Shields, because they are prerequisites to a lot of the MCOs where you need a Medicare or Medicaid ID to submit. So you don't want to delay yourself further down the line. You want to make sure you get those prereq payers out the door first. And lastly, another item to consider is start dates, prioritizing providers by start dates. But, specifically in a surge, a lot of them are starting, July 1st, August 1st. So there's not too much prioritization going on there. But, consider all of those things. Then from there, you want to make sure you build payer relationships. Notify your payers of mass submissions. Some of them may even allow you to submit rosters. If you have 50 providers going out, they may say, hey, we have a data set you can provide us with for these 50 providers, and then have them sign this one page versus having to fill out applications for all 50 providers, which is huge if you're in the situation where you might not have enough staff to get stuff out the door. Doing this obviously helps us, but it also increased response and processing times from the payers because you're building that relationship. You're creating transparency for them to see that you have a large submission coming through the door. Definitely important to understand that when we're understaffed, throwing staff at the problem only takes us so far. You really need to ensure that you have a tracking system, a standard process, and a game plan to get you through this busy season.
And again, it's listed under credentialing, but it's kind of across the board. Centralizing as much as possible. I think that's a huge kind of word, like buzzword in most organizations. And, if possible, clearly centralizing both payer enrollment processes as well as your MSO. But, obviously that's not always feasible, but it can be even done within your medical staff office in your credentialing department. So, looking at centralizing, the specific applications you're utilizing. I'm thinking more of kind of like a health system with multiple locations, and, DOPs can be a little bit different, a little bit difficult there of, centralizing those, but there are ways to go about doing that. So then you have, one DOP per specialty, that's obviously just specific to the organization, but yeah, there obviously are definitely ways to do that, and that gets them through the process a lot quicker and less documentation that has to be collected. Also, your committee approval process. So, if a practitioner has to go through 10 different committees, that's going to take a lot longer and a lot more work to get them through those committees. So if you can really centralize all of that committee process, that makes things go a lot quicker without those higher volumes. And so if you're preparing to be centralized on the front end, then when a surge does occur, like we are dealing with right now with all of our residents coming in, You know, it's not a huge disruption to your day-to-day operations, and it's just, you know, it's just business as usual. I also kind of like to bring up a little bit when it comes to reappointments as well. Again, especially in these health systems with many locations, I see oftentimes that we're not aligning reappointment dates. So, you know, a practitioner could go through multiple different reappointments why do we do that? They could easily go through reappointment all at once. You know, as long as they're not going past their expiration date, it's okay to reappoint them earlier. So you definitely want to make sure that those are aligned appropriately so they can just go through your reappointment one time. One time for that, obviously, for their cycle, and then, you know, years down the road when they come up for reappointment again. You know, another one too is especially knowing your committee dates. So in my hospital, I actually lumped all of my reappointments together. And so, you know, I had a large volume every single year at the same time every year, but then their expiration dates were always around like the holidays. So I had to keep in mind of, okay, when do I need to have them approved by prior to that expiration date, and then back it up to, you know, ensure that I'm sending out the requests in time and getting the information back and being able to process the files and get them on to committee. You know, again, we just want to make sure we have ample time to get those through the appropriate approval process. But again, if we centralize it all, it makes it a little bit easier for everyone. So with that centralized approach, obviously that comes with a lot of change within the organization. And like I said earlier, change is hard, but you know, our world is ever changing, and you know, we need to be flexible. But to do that, obviously there are some who are probably not as flexible as you would want in your organization, but I think a big piece is definitely involving those who will be affected in the discussion and in the decision process. So it's very important to gather any feedback from those involved, and like I said, bring the team into the discussion, because especially like us who are leaders who are maybe not in the weeds and in the day-to-day operations every single day, we might not know exactly all of the things that they're experiencing. So, you know, you make these decisions and it's good in theory, but once you put it into action, it doesn't necessarily work. So, you know, including them in those discussions and not leaving them in the dark. You know, they would be more willing to participate and embrace the change if they are more involved and feel like they're actually, you know, giving into the potential change. And then another item, I say be vocal. So it doesn't matter what your title is. You could, you know, you could be a vice president all the way down to, you know, coordinator or specialist. But you can easily position yourself as a strategic leader in the organization. And, you know, it does involve working with, you know, leaders throughout the facility and, you know, the different teams, and, you know, streamlining your processes and utilizing your resources effectively. Oftentimes we are the last to know about a new practitioner, and then, you know, we're being forced to really, you know, go and get them done and get them through the process. But, you know, if we're involved in the discussions early on with your leaders, then, you know, it doesn't come as a surprise, especially if, you know, there's a big contract change with different physician groups, that's always. You know, that gets pushed onto you, and they have to be done and ready to go in, you know, 30 days. Well, if we knew that kind of you know, as they're having the discussions and talking about the contract and everything, then we can go ahead and prepare ourselves for that. You know, one thing was, you know, I led a physician onboarding team where, you know, we met with a bunch of different people in the organization that included IT and HR and payer enrollment, risk management, quality, the executive assistant, and even medical records, because we want to know who's in flight, who's going through. Are there any, you know, rumors of people coming through? So, you know, by kind of getting that on the front end, then we can prepare ourselves. And then again, if you're involved within the organization and vocal, then a lot of times people know, okay, I need to go to the medical staff office. I need to make sure that they're aware of it. I need to, you know, I can't just throw it at them. And so that was one thing that I know I kind of instilled in my hospital. I mean, even down to the point of people trying to ask for access for a practitioner, and IT would shut it down and say, nope, that did not come from Amy Magnet, so we will not be moving forward. So, you know, when you have that collaboration and everybody knows the appropriate processes to go through because you have, you know, inserted yourself into it, you know, you can help spearhead those improvements, and they know to definitely come through you and make sure that it's done appropriately. And, you know, like I said, it doesn't, you can be the title of coordinator or specialist. You can still insert yourself into decision-making processes, and that can include potentially like you know, software resources to help with, you know, the volume and all these practitioners coming through. You know, you're the subject matter expert here, so, you know, looking at updating your procedures and revising, you know, your bylaws. But, you know, definitely do your research, bring your return on investment if, you know, an electronic database is needed, and that, you know, if you may need additional resources. So again, speak up and make sure that, you know, your leaders are aware of exactly what you need, so obviously you can effectively handle all of the things being thrown at you. Okay, we're going to quickly kind of talk about some of you know, the compliance items that come with the new NCQA and Joint Commission changes. So at this point, everyone is very familiar with NCQA and their changes that went into effect on July 1. So at this point, you know, we are in our period now, and you know, all your policies, agreements, and processes should be updated and in effect. And you know, this clearly primarily targets our payers and health plans, but you know, any of those that have delegated agreements with their payers clearly have to follow the standards as well. You know, when it comes to your shortened verification timeframes, you know, that will definitely impact some things there. You know, I would say, you know, especially when it comes to the surges coming in and having all of the volume, you know, for us being a CDO, we have, you know, it's 90 days to send it to our customers with our verification timeframes, and then it's just 120 days for these organizations. So they have only, you know, an additional 30 days after that to committee. And I will say it's one of those things that we got to make sure we're compliant with, and, you know, utilizing your resources that are available to ensure that compliance. But, you know, I will say I somewhat kind of agree with NCQA kind of making those changes, and sorry if that's a sore subject. You know, it's ensuring that these practitioners are getting through and getting approved, because I think, you know, obviously there was some issues with, you know, getting them through and getting them enrolled with the organization. So it's a huge shift, and I understand it. But yeah, and then also going into those monitoring requirements and ensuring that you know, you have your Medicare and Medicaid exclusions. And I think the biggest change, especially, are those monitoring your license expiration dates. You know, while that's very, very normal for hospitals and health systems, because, you know, we have to pull those verifications, make sure they're updated prior to expiration. And now, you know, NCQA is adding that in. And so if anyone doesn't know, yes, it was on a requirement for after NCQA in the past. And so I know that was a big shift for everyone. But regardless of your size of your organization, at this point, a platform is absolutely necessary to ensure that you're compliant. You know, it does assist in addressing some of those standards, and you know, you can have certain triggers and things like that pop up saying, hey, this is reaching your 120 days, or this has gone past 120 days. So now you need to review it prior to sending it to committee, because you need to make sure those are in the appropriate time frame. So there's certain things that, you know, those platforms can assist with. And I think the biggest one there is going to be your information integrity. That's very important when it comes to having those databases, ensuring your system is capable to complete your audits and effectively being able to capture those updates and essentially your audit trail. Because, you know, that clearly has been expanded and something that NCQA looks at heavily. When it comes to Joint Commission, at this point, it hasn't really affected medical staff. You know, they've condensed their standards mainly for the environment of care and life safety into one chapter, and that's cutting over 700 standards, which is crazy to me, but amazing. And, you know, as those changes begin, I'm sure, you know, it will start to see kind of some of the other chapters being reviewed and looked at, because I say it all the time, medical staff chapter has not changed in quite some time. So, you know, I'll be very interested to see exactly, you know, kind of what comes down the pipe. But I did also want to remind you that we do have some checklists as well that helps with kind of the basic process of like an NCQA, a Joint Commission, or it's kind of a CMS based process, and then as well as onboarding checklists. I know we have some enrollment items as well. So, and I think a big thing, especially with those checklists, is you can kind of see side by side exactly like here's kind of some enrollment items, and then here's the Joint Commission side of the house, and now let's look at them and see you know, where they're the same, and you know, you can kind of see the similarities in those processes there.
For sure, yeah, and you will see on the enrollment checklist that most of what the CVO or PSV team needs is exactly what we will need, with the addition of, you know, CAQH usernames, passwords, authorizations, and payer signature pages, things along those lines. Something I just wanted to add here with regard to the NCQA and Joint Commission changes in relation to payer enrollment, especially if you are an NCQA or Joint Commission organization, is you want to make sure that your CAQHs are up to date and reattested every 120 days with all pertinent info and provider practice locations up to date there. You also want to make sure that any new information is reported to payers within 30 days of the changes, whether that's, you know, your newly credentialed providers, your updates, terms, location additions, reappointments, things like that. You want to make sure that you're reporting those to payers in a timely manner, and also make sure that portal verifications and payer roster verifications are taking place quarterly. Big one is definitely availability. They're asking for us to review their portals quarterly, even though it feels like nonstop. So those are really important to make sure that you're taking care of those to ensure that you're within compliance with your payers.
And we're going to pause just for a moment for a little bit of fun. We have some trivia. So if you could enter your answers into the chat. Like I said, we just want to kind of break it up a little bit. And yeah, we will go on to our first question here.
All right, so starting off strong, since this is a NAMS credit, we wanted to start off asking, what year was NAMS, the National Association of Medical Staff Services, founded? Just add your answers to the chat.
We're seeing 1971, 76, 79, 85, sometime in the 70s. And the answer is?
1971.
Good job.
Terrell got that one, I think.
Okay, and then we got our next question. Although we have a lot of physicians out there nowadays, but who are the two physicians whose actions highlighted the importance of the credentialing industry? We'll say two highly profiled practitioners.
Dr. Swengo, Dunch, Swengo, Christopher Dunch.
Yep. I'm about to say, I think at this point we all should probably know who Dr. Swengo and Dunch. So both, you know, obviously we're nicknamed Dr. Death. If you haven't read The Blind Eye, please do. I think that definitely opened my eyes when I first started in the industry, and he never even completed a residency, and you know, now he pleaded guilty for 4 counts of murder and was involved in 60 fatal poisonings of patients and colleagues. And obviously, I think we're very familiar with Dr. Dunch, and I mean, even they came out with a sitcom, right? But the podcast, if you have, again, not listened to the Dr. Death podcast, that is, I actually listened to it twice. Once to, I think it was my CAMS conference in Colorado. Once there, and then the other one was to a COVID conference with the risk manager. And it was, I remember just like chills thinking, oh my gosh, this had to be before NPDB, right? All of this should have been reported to NPDB. No, yeah, 2015 through 2017, I can't even believe that. That's, I feel like this is just so recent, but I mean, we see it every day, right?
All right, rolling right along. Which company founded in 1985 was one of the first to develop provider data management software designed to handle credentialing, privileging, and enrollment functions? Yeah, looking in the chat, seems like everybody's got this one. It is Cactus, which is today known as S-Provider.
Okay. And next is how many days does a digitally savvy professional go without hearing the word AI? I feel like it's every second of the day, right? Especially in our world where, you know, we're dealing with product and different databases. That's out there all the time.
Lots of zeros.
Mm-hmm.
I mean, practically, yeah, less than a day. There you go, there's the answer. So that is, if you go more than a day without ever hearing that, kudos to you, but it's very much out there, and you know, that's something we're gonna have to look into, which we will, don't worry.
All right, this next one's just for fun. Everybody, you know, gets credit for this one. If you could play a theme song for every time you completed a successful credentialing file or got a PAR enrollment notice, what would it be? And just to start you guys off, I'm going to share mine. I feel like if it was a really challenging enrollment that maybe they denied multiple times for silly reasons, I feel like it would be We Will Rock You by Queen. But if it was a nice one, where it was a quick and easy enrollment process, I think I would say We Are the Champions by Queen, but gotta go with Queen.
Yeah, and I'm not gonna lie, I went into AI and I asked what they thought. It's quite funny what they say. So one of them said, every time a practitioner credentialing file was successfully completed, after all the chasing down licenses, primary source verifications, and signature marathons, it would be Eye of the Tiger. And why? Because completing a credentialing file is a bit like going 12 rounds with bureaucracy. It's persistence, attention to detail, and triumph all rolled in one. That final boom moment when everything is approved deserves the musical victory lap.
Nice.
I know.
Some fun ones in the chat too. Celebration by Kool and the Gang. We have a theme from Rocky, Yeah, by Usher. Another one, Bites the Dust. That's a good one. Tute Vas. Ringing a cowbell when we finish a file. That's cool.
Yes. I think my hospital would have hated me if I did that. Okay. Well, that was fun. Thanks for participating. Okay. So we will quickly go on over to our last topic, and it's how we can use AI and automation to better support our work. So it is an excellent option, obviously, to help with automating our work, doing data extraction, error detection, workflow acceleration. But there are obviously some things that AI cannot do. So some of the things that they can do to help as our volumes increase are, most of the time I will say a lot of people use their electronic apps, but for those who potentially are still on paper, there's AI out there that can read you know, written apps and be able to data enter that into the system. There's a lot of importing and exporting capabilities. You know, a lot of those APIs that are out there that kind of, again, take off that administrative burden, so then you can focus on a lot of those things that AI can't necessarily do. There's the expirable management piece. There's a caveat to that, kind of goes into both buckets. Obviously there's a lot of triggers, and then we have our web crawlers and image capture. We talked about Cactus / Simpler Provider, and they have license monitoring that captures that image and updates the date for you and all of that. But then also you have things that AI cannot validate your image and your data to ensure it's correct. That's kind of the caveat of that.
Another couple of really great items that AI can help you do are form and application population. So, you can map forms that need to be submitted in PDF format to payers, or, even providing credentialing notices to providers when they're credentialed by cred committee. Then there's also application population via the portals. So you can actually, use a software that's programmed to fill out portals for you with the click of a button, which is really great, especially if you're doing tons of apps during a surge. Another item that AI can help you with is predictive analytics. So it can help you kind of assess bottlenecks for payer processing times and responsiveness, even delays based on specialty or region and state, or just past timelines on how quickly it took applications to process that you guys have already submitted. So some really good features, definitely, that you can gain from incorporating AI or automation to the process.
Yeah. And then going on to the other side of what it cannot do, just like I mentioned, we're still responsible for our data and we need to ensure it's correct. So that's definitely something that, it requires a human being to do. AI cannot interpret any nuances, and I feel like a lot of our processes, there are a lot of nuances. So, if it does this and it's that, if it's this and it's that, so it cannot predict those things necessarily. It can't navigate policy changes. So when we're looking at all of our standards that are updating, it cannot compute those. So it will always have to be recoded if you have any of those changes. So that is definitely something to remember. And it also cannot foster provider relationships. Again, that requires human interaction, and it's definitely essential to an efficient, credentialing and payer enrollment process, as well as keeping your medical staff happy.
Some other things AI can't do. It cannot escalate with payer reps or MSOs. You need human touch to do that. You need a person building relationships to be able to do that successfully. It also can't navigate portal changes, right? Because you have to program AI to do what it does. So when something changes or is updated within a portal, that requires the update to your automation before it will actually physically change what needs to be updated within the process. Another one is providing representation for appeals, whether that's Medicare, Medicaid, whatever the situation may be. It might be able to help you, write a nice letter, but it can't present a case for you and it can't fight back. So just some really important things to remember, that, while AI is really useful, you will still always need a human to do things for you. This is just a quick slide about what AI said about AI. So I asked ChatGPT this question, and it gave me like a really nice little visual. So we pasted it here. We pretty much covered a lot of these things, and we just wanted you guys to see this. I thought it was interesting that it could tell us things about itself that might be a limitation.
Yep. Okay. Awesome. We will move on to questions. If anyone has any questions, please put them in that little questions tab there. Again, please ensure that you download all the assets that were provided. So we have our NCQA checklist, Joint Commission checklist, onboarding, and enrollment checklist. And please stay on afterwards, because we do have a survey. We do want to hear from you as well.
Yes, and while everybody's typing their questions, regarding that survey, we are going to be asking about payer enrollment 201 webinar. We want feedback from everybody on the call to understand what you all would really feel is valuable for a more in-depth payer enrollment session. Maybe that's, you know, standardizing your processes across your teams, or maybe that's a deep dive into Florida enrollment processes with, you know, Florida Medicaid and all the MCOs. These are just some ideas, but we would really like to hear from you guys in the survey on that. So if you can, please fill it out.
Yeah. Now, if there are any questions, sorry. What resources are available to assist with the enrollment process? That would be you.
Yeah, so we do have a resource in this chat here, the enrollment checklist for onboarding. So we have that. It tells you all the documents and data elements you're going to need from a general provider onboarding perspective. There may be some state-specific information in there that won't be in there, but we've covered pretty much everything that we've seen across, you know, the nation there. And then on top of that, we kind of also included a punch list to kind of give you steps A to Z, key elements in onboarding a provider from the payer enrollment perspective.
Yeah, and I think, how do people deal with state mandated applications that are updated annually? That's tough. I was in Colorado when it was mandated. They're not anymore, but you know, every time a revision came, I had to ask a practitioner. Sorry, I can't use the old version, but I think that's where a lot of times, you know, looking for a platform that can help with that and map them and keep updated on those state mandated applications is really going to be necessary.
Here's another good one for enrollment. Does anyone enroll providers with payers before they're approved by the hospital board of directors, or do you wait until the committee processes are complete? This 100% depends on whether or not you're delegated with the payer. So if you are delegated with the payer, you can't send them out on a roster until they've got CRED committee dates and have been verified by your PSV team. If you are non-delegated or it's a government payer, as long as you have the required data elements for that submission, whether it's Medicare, Medicaid, or any of the commercials, you are able to actually start your enrollment process alongside your PSV process. So rule of thumb, non-delegated enrollments, you can absolutely start without having a CRED date. Delegated enrollments, you need that CRED date before you can report to payers.
There's another one that's flagged. What are common causes of enrollment application denials or delays, and what steps can be taken to prevent them?
That's a good one. I'm sure everybody who does enrollment on this call knows sometimes there's nothing wrong with the app and you attached everything and they still ask you for something. But I would say a lot of the times, if you have an experienced enrollment specialist, you know, doing the work, you're not going to get too many errors unless the payer maybe changes a process or regulation and you're not aware of it. So something to make sure you consider is staying up to date with payers and their policies and regulations, as well as any changes to their processes. You know, you could have a team fill out enrollment applications that you thought were current, and you go to submit them and they're all denied because the payer actually created a new form that they've put into process that they need you to use. So definitely make sure you're looking at that. And also make sure that you are clearly answering all of the questions on the application, filling out every one of the checkboxes. If something you think doesn't need to be answered, you need to write NA in the space, leave nothing blank, and make sure all of the required documentation is attached. You know, throw more in rather than giving the bare minimum. so that there is no back and forth with the payers.
Perfect. Well, I think we are at time. So I do want to thank everyone for joining. Yes, this is recorded, so you can reference it again. Hopefully we'll see you at NAM, so stop by our booth and say hi. Also, additionally, again, we'll have a brief survey right after this ends, so please stay on. We want to hear from you. And thank you, everyone. We will also answer your questions. We'll send them out individually, we promise. So have a good day, everyone.
Thank you very much.